Okay.
And I'll just give you a brief, give me a second here, kind of my overview, general advice for you, and then we'll kind of move on into those, okay? And in general, when you do the test, they're going to try to get through about 3 scenarios in a room. Take your time with them, pace yourself. If you know the answer, go even slower and just take your time with it so you can get all the points for it. If you go too fast, you end up getting into a situation where they're going to give you some question that maybe would have been a lot harder, and you end up kind of struggling with something. Relax, take a deep breath before each room. It works every time. It will drop your heart rate and make you feel more comfortable. Go in clean shaven, well dressed, calm. You want to balance your confidence with humility. You want to be confident in the sense that you know that what you're saying you think is the right thing to do, but you don't want to be so overconfident that they think that you'll be too confident in practice and make mistakes and not think things through or do procedures that you really shouldn't do. It's okay to say you don't know the answer. It's also important to say that, because you may end up with a situation where you're at a point where you don't know. It's at the limit of your practice or what you know. And it's better for you to say you don't know than to make something up or kind of get partly there, because then they also view that as dangerous. Have a system in place and stick to it. Always ask a full H&P, always do the labs, always do the imaging, always think if you're deferential, and always provide a treatment plan. Specifically, the things to look out for is if you don't ask for allergies, they're going to be allergic to something you give them.
Okay.
If you don't ask about creatinine, you're going to get a CTA in someone with, renal failure that's not on dialysis and put them on dialysis. If you don't check for heparin allergy, you're going to get someone with HIT, right? So always check for those things, and then just take your time with it. Okay.
Okay. Yeah.
All right. Another thing. Yeah. So when you're on the test, there'll be these magical questions that lead you to this point where they kind of bring you to an operation that you've never thought of before. And you're like, I've never thought of this, but this might be the exact right thing to do. At this point in the game, if you haven't seen it, you haven't heard a friend talk about it, never mentioned it at a teaching conference, not the time to bring it up. Okay. Put that in your head, think about it later. You'll come up with all kinds of aortic reconstructions that you never did. It's usually not the right answer.
Okay.
If you haven't done it yet, it's probably not the right answer. Okay.
Yep.
All right. So we're going to go ahead and start with this first one. Let me start a timer for you. Okay. So your first patient, yeah, can you see the screen? Sorry.
Yeah, I can see it. Perfect.
Great. So your first patient is a 31-year-old female with type 2 diabetes and hypertension who's referred to you for evaluation for hemodialysis access.
So I would see her in my clinic. I would start off with full history. I'd want to know, what she takes for her diabetes, how well controlled that is, how well controlled her hypertension is. Has she ever had any hemodialysis access in the past? Any family history of kidney disease? What caused her kidney disease? Is this something, polycystic kidney disease? Is this hypertension? I'd want to know that, as I'm planning for her surgery. And after taking a full history, I'd also want to know any other past surgical history, past medical history, what medication she's taking, including any anticoagulation, allergies, including heparin, and anything else. And sorry, I would also want to know if she was a smoker. And I would start with that history.
Okay. So she doesn't know of any prior access. She doesn't know why she has this problem. She's just she's on metformin now. She's on 2 medications for her hypertension. She doesn't know of anyone in her family who's had problems like this. She doesn't currently smoke. Anything else you want to know?
I'd like to know which, is she right or left hand dominant?
She's right-handed.
She's right-handed. And any previous trauma to the right or left arm, any debilitations that she'd have in either arm?
No.
And then I'd also want to know, has her nephrologist discussed with her what type of access she wants? Does she want, she's here for hemodialysis access? Does she want peritoneal dialysis? What exactly?
She doesn't want to do peritoneal dialysis. She wants hemodialysis access.
Okay, so then at this point in time, I'd go ahead with full physical exam, and I would.
Okay. Anything else you want to know from the history?
What's her creatinine at this point in time?
She doesn't know her creatinine from her.
She doesn't know.
Yeah.
And she's not on dialysis yet, or does she have any catheters or anything?
She doesn't. Her nephrologist told her she's going to likely be on dialysis within the next 3 months.
Okay. So I think at this point I would move towards a physical exam.
Okay. And what are you looking for?
So I'd want to do a full head to toe physical exam. She's a new patient to me, but I would want to focus on the bilateral upper extremities. I'd want to look for scars that could be any old injuries. I'd want to do a pulse exam looking at the brachial, radial pulses. I'd also want to do just a neurologic exam of the bilateral upper extremities as well.
Okay. Her exam overall is pretty unremarkable. She looks a little bit volume overloaded and edematous. She has slight crackles in her lungs. She's got palpable brachial and radial pulses. Other than that, nothing remarkable on your exam.
Okay. So at this point, I would want to send her for bilateral upper extremity Dopplers looking at vein size as well as arterial size on bilateral arms.
Sure. So this is what you get back.
Okay, so just interpreting this, starting at the top, she's right-handed, so I would want to go on the left side to start, if that looks okay. Her brachial artery distally appears adequate. Looking
What is
down,
adequate for you?
so an artery size of at least 2 millimeters.
Okay.
And then looking at her vein, again, looking at the brachial and the basilic, the cephalic and the basilic vein. I'm looking in the forearm. I'd want to start as distal as possible. Adequate for me is 3 millimeters. So I'd say that distally she's not adequate, but she has an excellent cephalic vein in the upper arm.
Okay.
So I would talk to her about a brachiocephalic arteriovenous fistula. Before that, however,
what the risks are to that procedure.
of course. So I would discuss with her, common surgical risks, including infection and bleeding. But more importantly, I would then also discuss with her access-specific risks of, injury to the artery requiring revascularization. I would discuss with her Steele syndrome, where we're creating a pathway from the artery into the vein that's not normally there. That blood would normally be going to her hand, and so sometimes she can get ischemic symptoms of the hand. And the most dreaded of all, she's a diabetic, and so she'd be at higher risk for something called ischemic monomelic neuropathy, which is very rare. Less than 2%, but something that would require emergent ligation of her access.
Okay. She doesn't understand everything you talked about, but she trusts you, and so she's agreeable to move forward with what you would recommend to do next. So what would you recommend to do next?
So before I would schedule her for surgery, but before I did that, on my physical exam, she had crackles, she was overloaded. So I would want to get a CBC, a BMP, coags as well. To see where she's at baseline. I'd also want to get a chest x-ray to see how overloaded she was.
So her CBC looks pretty normal. Her x-ray actually doesn't show a lot of fluid. Her coags are normal, and her BMP shows that her GFR is about around 10.
Okay, so I would discuss with her nephrologist, just to make sure that, this is her baseline. I wouldn't want to take her and have something go wrong. If I need to put a temporary catheter in, I could do that as well. But at this point, barring that, I would consent her for a left brachiocephalic arteriovenous fistula. I do this.
Okay. So explain to me from the moment she goes into the operating room what your plan is, including your anesthetic plan and how you conduct the operation.
Of course. So as soon as she got into the operating room, I do this in the operating room under sedation. I have my anesthesia colleagues usually give a little bit of propofol and monitor her completely under sedation. And prior to prepping and draping, I would do my own vein mapping with ultrasound to plan out my incision. I'd mark where the brachial artery was, where the cephalic vein was, make sure the sizes were okay, make sure she hasn't had any issues since I did her vein mapping. Once that was done, I would prep and drape her in the normal sterile fashion.
So when you do when you go into the operating room, when you're doing when you decide upon sedation, before you prep and drape, do you do anything else?
I would make sure I marked the correct arm. I would check to make sure she had a pulse in that arm as well.
Okay, so when you go to mark her arm, her cephalic vein actually looks like it's been accessed a few times since you last saw her. There's an area where it looks pretty small in the antecubital fossa, and for about 5 centimeters up from that. Her basilic vein still looks to be consistent in size to what you had in the report before. So it's over 3 millimeters in the upper arm.
Okay, over 3 in the upper arm. So you know, prior, I would have when I do this ultrasound before I do the ultrasound before sedation. So, you know, at this point in time, the cephalic does not look appropriate. I would again evaluate the basilic
That one
if
looks fine.
it looks fine. So I would discuss with her before the sedation that, you know, the plan has now changed. While her vein looked good preoperatively, we're going to switch to a basilic vein
Okay,
fistula.
so let's say she was okay with that. You're in the operating room. They've started sedation. She's prepped and draped. What do you do next?
So over my previously marked incision, I would use 1% lidocaine, and I
Anything
would
you do before you inject the lidocaine?
I would just let her know that I was about to use it and about to inject her.
Okay. So the nurse stops you and says, let's do an all-stop timeout. You do your all-stop
Okay.
timeout and you correctly identify the patient inside. You discuss your antibiotic plan with the anesthesiologist and you discuss your anticoagulation plan with them. And after that point, you make you use your local anesthetic to make your skin incisions. What do you do now?
So at this point, I would dissect down and identify the basilic vein. I would dissect the basilic vein carefully and loop it for approximately 4 to 5 centimeters. Any branches, I would also ligate. Once I had an appropriate vein out, I would make sure that was looped, and then I would open the fascia and dissect out the brachial artery, taking care not to injure the paired veins around it. I would dissect that for approximately 1 to 2 centimeters and loop that as well. At this point in time, I would give the patient weight-based heparin, 100 units per kilogram, let that circulate for 3 minutes. At that, and then I would clamp the distal vein, cut that over, tie that off with a silk tie. I would then cannulate that with heparinized saline on an angiocath and make sure it was able to pass and had good flow. At which point I would put a bulldog on my vein and spatulate that. Then I would go ahead and clamp my artery proximally and distally, and I would make an arteriotomy no more than 6 millimeters with an 11 blade and extend that with pot scissors.
So you clamp that artery proximally and distally, you make your arteriotomy, and you're having a hard time get the 11 blade to go through the plaque.
Okay, so I would switch. I would use a 15 blade at this point to gently make an arteriotomy on the top.
You make that, and the artery has all these little bits of plaque in it. The wall's pretty friable. It kind of tore when you cut that, and so now you've got a kind of a gaping hole in the artery. That's about 6 millimeters in length, and you see a lot of plaque, and it seems pretty crunchy.
It seems pretty crunchy. Okay, at this point in time, I would, I would extend my arteriotomy a little bit and perform an endarterectomy on the artery at that point in time to get out the area, making sure that if there was any flaps proximally or distally, I would tack that down to prevent it from coming up. And then I have 4 or 5 centimeters of vein out. If I needed to, I would patch that and then perform my fistula on top of my patch. If I was able to stay within 6 millimeters, I would just
so you patch this artery and you try to reestablish flow, and you don't have flow with the hand.
Okay, so I don't have flow at the hand at this. Now I would.
So your next patient is a 65-year-old left-handed female who has a right-sided brake axe graft, is now complaining of pain in her right hand during dialysis.
And she's in the office?
Yeah. Yeah, she
Okay.
comes to
So
you
I
for
would,
follow-up after you place this graft, and she says when she's on dialysis, she starts to get pain in her right hand.
Okay. So I would see her and again take more history. I would ask her about her pain. It's associated with dialysis. Is there a certain time? Does it happen when she's not on dialysis? What exactly happens? Is it a burning sensation, a stabbing pain? I would ask about associated symptoms, including numbness or weakness in the hand. I would also ask her if she knew what type of graft was placed, how long ago it was placed. I would then ask her about her past medical history, wondering, is she diabetic? Is she a smoker? Any cardiovascular risk factors? Any other surgeries she's had or injuries to the hand recently? And then I would ask allergies and let her tell me that now.
Okay. She doesn't smoke. She doesn't have any allergies. She's on appropriate meds for her medical history, which is inclusive of, diabetes, hypertension, and coronary disease. Her past surgeries relevant to this include a prior failed right-sided radiocephalic fistula, a failed forearm loop graft, and then what you put in was a 4-7 tapered graft. And that was put in about 3 months ago. And about a month